Good morning, ladies and gentlemen. Good morning, good afternoon, good evening, depending on where you're joining. You're welcome to this webinar that is focused on community-based tracking of immunization programs, otherwise known as COMBAT. It is a project that was implemented by the Johns Hopkins Bloomberg School of Public Health with the kind support of the Gavi the Vaccine Alliance. And it's our pleasure today to share the findings of our study. And we are joined this morning by our esteemed colleagues from Gavi, who will give us goodwill message to help set the stage for this webinar. We also have the pleasure of being joined by colleagues from the government, which I will introduce in a minute. So on the screen, you will see the agenda for the webinar. It's a 1.5 hour time together that we have. And then in the first 15 minutes, we will have welcome remarks. And then from there, we'll go on to the overview of the study methods, where you will get a sense of how we conducted the research. And then after that, you will get the findings from the research that we conducted in 4 countries: Bangladesh, Cameroon, Madagascar, and Nigeria. After the findings presented by our co-PIs from the countries, we will now have the pleasure of sitting down, or so to speak, having a panel discussion with discussants from 3 countries. Then we will open it up for question and answers and then wrap it up. So once again, it's my pleasure to welcome you to this webinar to give us an overview of the study we conducted looking at how to improve immunization outcomes using community-based monitoring and tracking of immunization. So with that, I would like to introduce my next speakers, Ms. Christina Scaduto. She's an advisor to the Chief Vaccine Programs and Markets Officer at Gavi, as well as Dr. Sud Mani, who is a senior specialist for MEL at Gavi. They have been thought partners with us throughout this journey and have provided not just the funding, but also critical input and feedback into the project, and as we designed, developed, implemented, and are now reporting the study. So over to you, Christina, for your opening remarks from Gavi. Thank you very much.
Thank you so much, Chizoba, and to our Hopkins colleagues for the warm welcome. Good morning, good afternoon, everybody. Really delighted to be here. And on behalf of Gavi, I'm very happy to welcome you to today's webinar for the Comeback Project. This initiative really represents a vital step forward in our collective efforts to strengthen immunization systems through community-based tracking and monitoring. Over the last couple of years, the Combat Project, led by our partners at IVAC, they've worked very closely with different civil society organizations across Bangladesh, Cameroon, Nigeria, and together they've generated a considerable amount of rich community-level insights at both the national and global levels. Today's session is really an opportunity for us to come together and reflect on the progress that is made, share key findings, and explore how the combat approach can be scaled and be sustained in the future. We're especially proud of the work that this aligns with Gavi's strategic goals, and also as we embark on a new strategic period in 6.0, but also under the IA 2030 and our commitment to equity and country ownership. I want to thank all of you, our country partners, civil society organizations, technical experts, and our alliance partners for your dedication and contributions. Your insights are shaping the future of immunization, and we look forward to continuing this journey together. Over to you, Sud, for any comments from your side.
Thanks, Christina. Thanks to the entire IVAC team. I want to congratulate you for this particular work because it's been an incredible uh, co-development of these recommendations. I know how much of efforts have gone into it, and it's coming out at a very apt time when Gavi 6.0 it's kicking off, and it's more on country facing and country centered approach which Gavi is proposing in its 6.0 strategy, and it's not possible before without the community based organizations. And whatever the findings of this particular research work is going to be put in use, as well as being helpful for several countries how to engage these community based organizations for tracking and monitoring routine immunization activities. So far, it has been happening ad hoc. There can be more channelizing of it, strategizing how community based organizations can be involved, and more streamlining of this monitoring, which will not only help routine immunization as well as it will help the country's data systems as well, so that it comes closer to whatever the surveys can usually give in terms of what the routine immunization coverage is. So, on behalf of Gavi, I also welcome everybody who is attending this webinar, and again, a huge congratulations to the entire team. I'm also really looking forward to hear as an audience from the team what are the key findings, and also listen to what is the voices from the ground, what they have to contribute towards this particular topic on CBT, which is very critical for the implementation of Gavi 6.0. Thank you so much for also giving me an opportunity to give this opening remarks. And without ado, I hand it over to the IVAC team to take it forward. Thanks, everyone.
Thank you very much. And then next slide, I think, thank you very much. And speaking of sort of country ownership and country leadership, we are honored to have the director of the DCI program in Nigeria with us to join for sort of remarks from the national perspective and from the leadership side. Over to you, Dr. Garba. I hope he's able to unmute. Are you able to unmute? There you are. Sounds good. Thank you.
All right. Thank you. Thank you so much. Good afternoon. It's past one already. So good afternoon, ladies and gentlemen. As introduced, my name is Dr. Ahmed Rufai Garba. I serve as the Director of Disease Control and Immunization and a friend of all the partners. So my task here is just very simple. It's to speak to all of us in terms of how this support can actually make a difference at the levels that we want to see this difference. It's very important that we do this research, but it's more important that the findings from the research are put to use, are discussed like this in a dissemination meeting, and also actually acted upon by the recommendations that follow all of the work that is done on the field. Immunization is not just government business, as we know. Over the years, it's been a unilateral thing of government here and government there. However, it has come to the fore that if we need to succeed, the most important component of all of the layers that actually partake in the activities conducted by the immunization program, the community level is the most important, because that is where all of the caregivers are, that is where all of the children are, all the mothers are, that is where the conversation around hesitancy is most important, that is where the conversation around non-compliance is very important. And if we need to make things work, the community has to be given special attention. So that's why I'm particularly excited about this work. to see what the findings are and be able to probably influence policy or redesign strategy in terms of how we move. If the community has a stake and a full stake, and they fully believe that this is our program, the children are our children, and they totally and fully participate, I think we'll have a totally different result from what we're getting right now. What has actually held us back is because we have not been able to get the community to move with us. And we've seen that any program where communities come on board at the early stage and move all the way up to the evaluation stage, the results are usually better. So yes, I want to appreciate the team that actually conducted this work. And I am hoping that the dissemination will not end here. There's the what next after this. And that's what I'm interested in. What will all of this translate to in terms of how we increase coverage? Because the business of NPCD, one of the business of NPCD is basically increase coverage, reduce zero dose, and have to breach the immunity gap that leads to all of these outbreaks, sporadic outbreaks across the country. If the community takes this upon itself, we will be able to achieve beyond the numbers that we have right now. And yes, so this is all very important to me, and not just to me, to the whole team, and to NPCD in general. So at this point, I'll say I'm wishing all of us very fruitful deliberations. But I need to add that clause. We need to also speak to the so what? This is what we found. And that, for me, is the most important part. We're all welcome to this all-important symposium. Let's be in the symposium. Let's participate. Let's ask the questions, the most difficult ones though, and let's also bring up suggestions if it's necessary on how we move this further. Thank you very much. Over from my side, Dr. C.
Thank
Thank
you
you so
very,
much.
very much.
Thank you so much, Dr. Rufai. You've heard from him. He notes that it's really important to carry the communities along, and we shouldn't just end at research. We should end at the so what. How does the research translate into number of children vaccinated, protected, and lives saved? So with that, I would like to invite my dear colleague, Victoria, to tell us about the project. Tell us about Combat and
Thank
what
you.
you did.
Thank you. And so my name is Victoria Chu, and I've been tasked with sort of walking us quickly through the methodology for how the data that we collected, how we synthesized. So next slide is, as Christina and Sud had mentioned, it's been sort of an ongoing collaboration with the overarching goals as you see shown here. And they're pretty lofty in terms of what we set out to do, and really to kind of understand what the data gaps and challenges are, to describe the current level of CSO knowledge. What do those working, the boots on the ground, the CSOs know about a term that we've sort of coined as CBT, or community-based tracking and monitoring? How is that playing out in terms of what are the current challenges these programs or initiatives are facing? What are the enablers? And then finally, as Dr. Rufai has mentioned, and Shizova, the most important part is taking this forward so that we can determine what we can do to leverage CBT that is ongoing, and then potentially expanding those efforts. Next slide. And so really this has been over about a year in terms of approaching this from different angles. And so our triangulation really focused on trying to understand from the first perspective, a desk review of trying to look at community-based monitoring, community-based tracking. What is some of the work that has been done, reported in the literature? And so the desk review tried to cast a wide net. We piggybacked and we're grateful to work closely, follow closely the work, seminal work of colleagues who were able to serve on our tag, Ginny Fonner and her team at FHI, who had already looked at some of the community-based monitoring and tracking approaches for widely a wide range of public health interventions and programs. And so we looked at it from the WHO health systems framework and understood what are the relationships with each building block. So that led to the formulation of our mixed method approach. And so the mixed methods approach really tried to say, we would like some quantitative data and then some really rich in-country work led by our country program managers to really understand what those numbers mean. And so the qualitative data was gathered through key informant interviews and focus group discussions, and what each country level presentation will go through is sort of a synthesis of what those findings were, both from the global side, the online survey that was run through Qualtrics, and sort of an information gathering that really can only provide a snapshot before you sort of get the input, the feedback, the quotes, et cetera, from the in-country CSOs. And so there, to date, has been one in-country workshop that was hosted in Cameroon. This is the second opportunity for us to kind of present and discuss and examine the findings. And so really excited that you all have chosen to spend the time with us, because really the most important part is that last step where the dissemination, hopefully, what are the next steps for this work, and where is this going to lead countries. And so with that, I'm going to turn it over to my first colleague, Dr. Nizam is going to present. We'll go in order alphabetically, and just sort of discuss the work that was done in Bangladesh, both informed by the quantitative survey that was collected with responses collected online, and then his amazing work really gathering and listening to folks on the ground. Over to you.
Thank you very much. And thank you, Victoria and the team. Respected the colleagues from Gavi, friends and colleagues, and the Johns Hopkins team, IVAC team, and most importantly, the country delegates who will be presenting, including the people who are joining here. I'm inviting you now to Asia and in Bangladesh. It's a fantastic country. Despite several global health challenges as well as political transitions, Bangladesh has made a significant progress. It's a newborn country, over 55 years now from the independence. Despite many challenges, country has made a significant progress in immunizations. And you can see that over 12 years, country maintaining the coverage 82% level. And the Bangladesh is rewarded by the award by Gavi in UN General Assembly as a vaccine hero to provide learning and opportunity and sharing the lessons learned from not only Bangladesh, but also to the rest of the global community. Our maternal child health, child health really significantly reduced because one of the major effective immunization program in the country. Polio eradicated from Bangladesh, maternal neonatal tetanus eliminated, and recently last year, the HPV vaccine among the adolescent girls, we achieved 93% coverage. Hopefully, that will really be exemplary work for preventing cervical cancer. And also the life expectancy of population in Bangladesh is doubling now from the birth of this country from 1970-71. Community health system here is extraordinarily great. We do have over 75,000 community health workers, along with the CSOs and NGOs who are delivering services nationwide and in all over the country. And Bangladesh is one of the countries being identified the international evaluation and ranking for the pandemic response in COVID-19, ranked #1 in Asia and globally 5th. And one of the beautiful part of Bangladesh is the collaboration and partnership, so that public-private partnership, NGO, CSOs are driving the health outcomes with the growth in digital platforms, which is existing and growing faster. Despite that, we do have challenges like health workers vacancies, geographical barriers, internal, external migrations, coordinations, and monitoring system for the immunization services. So that would be taking the country in the future to the next stage. So next 25 years would be different. I'm just showing you at a glance very quickly, 25 years immunization trends in Bangladesh. Immunization started in 1979. And now if you see the number top one, almost 100%, 99% of the children receive BCG and DPT, which is really very, very impressive. But over the period of time, if you see the last one, which is the full immunization coverage, that's 82%, meaning we are missing children, we are missing demand generation activity, we are missing the partnership at the community and more engagement at the community. That's where the CBT, community-based approach tracking and monitoring system, would be playing a biggest role. Rural, urban, there is a difference. So that urban area is more congested and having more challenges, where our CSO partners and colleagues are working together to improve it the next level. The next slide, I'm going to, with this impressive scenario in Bangladesh in immunization landscape with public health, but also I'm going to be presenting you the immunization challenges that we are facing at the moment. And a study, as mentioned, Victoria, by clearly the methodology of the study is a mixed method. Our survey respondent clearly mentioned that which immunization area lacked the necessary data for performance monitoring and accountability. And that's where the CBT comes in, and more importance to draw here. Looking at the figure here, you can see the two major areas where we need to look at how to make it better: health information system, and also we need data for evidence-based advocacy for policymaking and looking to the next generation. As Christina mentioned at the beginning, Gavi 6.0, looking ahead in the next 5 years. So all the country looking ahead with the partner, how to improve locally and nationally as well. In addition to demand generation activities needs to be further improved and looked at quite closely with the data. And also the leadership, particularly most important area here I would like to mention. Bangladesh is implementing 12 antigen at the moment. It's going to be increasing next year and following years. So meaning we need strong leadership and good governance system in place, not like last 25 years. Rather, we need to see next 25 years how we can improve. That's where community level engagement and utilization and benefit of CBT will be coming into. Next slide, please. If I would like to present quickly the CBT status in Bangladesh, current approach to CBT-like activities. For example, work is informal, community-based tracking and monitoring. It's ad hoc and paper-based monitoring. Typically, methods use home visit register and also default tracking by the individual community health workers and CSOs. And also that, we do any CBT-like activities, say, follow their own approach with no standard workflow or digital link with the DSS2. I would like to mention that Bangladesh used the demographic health information system here, and data collection on daily and weekly and monthly basis. That report comes to the EPI system. The study clearly identified that the perceived benefit of a formal CBT system, the CSO and EPI managers see clearly benefits once the idea is explained to them during the study. And the real-time list of zero dose and defaulters, especially the urban slums and remote area, are noted. And very strong community ownership comes through this CBT system, quicker rumor control activities, and building the trust as well. So that's really play a better target setting, as well as the eligible before the session start by the EPI system. And in addition to that, CSO always become an extension and supporting service to the government, particularly to strengthening the surveillance system at the community level. Next slide, please. Now I'm going to present you the finding from the study in Bangladesh, and I follow the immunization pillar here. I will go over very fast, and please stop me when we need to ask questions, like the service delivery area, API and the service delivery data enter into the DSIS2 in Bangladesh. So it's quite digitalized system in the progress. But how about there are gaps in DSIS2? We know that there's no tracking of missed or refusing children, accessing barriers, rumors, or vaccine hesitancy. So thereby, no community level dashboard. Only 1/4 of CSOs feel rumors are adequately monitored. However, the frontline workers use paper registration and also submit monthly report, which always have a negative impact on the data quality. Looking at the leadership and management and governance, policymaker advocates lack sufficient evidence, effectively encounter misinformation. And community-based tracking is now to both national and district level managers to look at how it could be potentially useful to enhance the program accountability and sustainability as well. And CSO's role are very strong here in order to support the community-driven approach, but funding is a huge crisis all over. We all know that. And there is a push all the integration with immunization with the primary healthcare system. And we all know that here from the study clearly identified that majority of the CSOs working both national and also the district and subnational level. And they're able to bring the information from the community, working with the community, engaging in the monitoring system, CBT-like activities. As I mentioned, CBT is not formally introduced here, but they do a lot of monitoring activities. And data collected remains in the meetings, and sometimes it's never reflected into the report. So we need digitalize and inclusion of CBT into it. Next slide, please. The next pillar is vaccine supply and cold chain management system. It's entirely in Bangladesh, depending on the EPI system responsible for managing the vaccine and cold chain system. However, the 51% of the CSOs in the study clearly mentioned that lack of real-time data monitoring and also infrastructure-related issue is there, and major focus comes somehow to the campaign-centric, mainly in the urban area. So there is a clear recommendation how to bring the real life at the rural and urban and all over the country at a time. The demand generation and community engagement area, this is the area that CSOs play biggest role in Bangladesh. Not only engaging community, building the trust is a major challenge, but the CSOs are working to tackle the rumor, but there are sometimes the rumors are not fully addressed properly, and engaging community is one of the biggest part where the relationship and trust are major key element from the CSOs. I need to progress next. Next slide, please. With these findings, we draw 7 recommendations from the study to improve the CBT utilization at country and local level. One is the policy and governance, where we talked about formal introduction of the CBT with the national EPI system. So thereby, it is not going to be ad hoc. It will be used as a major source of community engagement and monitoring of the vaccination and immunization at the community level. We definitely need standardized tools and user guides so that it can be utilized properly, not as an ad hoc understanding. And also it can be digitalized into the system so that adding CBT module into DSS2 would be the real great success and area to improve for the CBT here as well. That will help us to build the capacity. But also from the study, we strongly recommend that as our guest clearly mentioned about what is next, and we in Bangladesh, we think that we need to do some piloting on demonstration work to need to learn more and see more details, including in the policy, and that learning can take the scale to the national level immunization system quite well. Need to build up the feedback system so that we can learn and use properly. And on the top of that, partnership and coordination is the key with not only the government CSOs, but also the private sector and other partners around us in the immunization landscape. Next slide, please. In the last one, in conclusion, I would like to say that No Child Left Behind, the CBT really can help ensuring every child is reached with the life-saving vaccines. And it not only the vaccine, but also it helped to empower the community families so that community engagement can be not only as an obligation, but as an interest to engage by that. It will bridge between the community and the system, but health system and the community can be more trusted relationship and be accountable for saving life and saving children's life at the community, so that we can get improved and better coverage, reducing the zero dose, improve dropouts, and also utilize the enablers for improving the CBT utilization along with immunization system. Thereby, strengthening immunization system can sustain for the future, and we will look forward to utilize this powerful tool into the national immunization system in Bangladesh, so that next 25 years, it can leverage more impact, saving more life, and saving more learning to the world. Thank you.
Thank you so much, Dr. Nizam, for that clear presentation. Without wasting time, let's go over to Cameroon to hear what the results are. Over to you, Dr. Mbianke.
Thank you so much, Dr. Kizaba, and a warm welcome to all participants and panelists. A big thank you for the Gavi team, country program managers, the IVAC team, and everyone that has made the time to be here today. So I'm going to give us a Cameroon perspective and our findings from the country. As you all know, Cameroon is a very beautiful country in sub-Saharan Africa, called Africa in miniature because Cameroon is an intersection between all African cultures and way of life. It's a very unique country because of its bilingual nature, which is both English and French, of over 250 ethnic groups with different languages, cultures. So Cameroon, it's really rich in terms of learning. And yeah, Cameroon has made a very significant progress since its EPI inception. But however, we still have very, very big challenges as child death still remains unacceptably high. Maternal mortality stands at a high of 444 per 100,000 live births, with the main causes of child death being measles, diarrhea, meningitis, malaria, and acute lower respiratory tract infections. But despite that, Cameroon has actually made significant progress in immunization coverage, with coverage increasing and improving above 80% since 2007. However, due to the crisis and in the Northwest and Southwest, and in the North, Boko Haram insurgencies and natural disasters, immunization coverage rates have continued to be dropping down post-COVID-19 and also post after the crisis, during the crisis period, which is an opener that a lot needs to be done in order to maintain and also take to higher levels the immunization coverage. Next slide, please. Yeah, as I was saying, Cameroon child mortality still remains high, and our EPI program was launched in 1976 as one like a pilot program, which was supported by Gavi and partners. And the EPI program in Cameroon has greatly transitioned from being a pilot to actually being an entire and independent program in the country, which supersedes 10 regions in the entire country, with over 182 different districts, which form our basis of primary healthcare. Next slide. Cameroon has several immunization challenges, and these challenges varies across regions and across the different districts. So in the inception of the EPI program, the goal was to protect life and prevent deaths due to vaccine preventable diseases. And over that time, Cameroon EPI has contributed a lot in reducing infant mobility and mortality. And through its organized programs, strategies to reach rural communities, urban slums, Cameroon EPI program has done quite significant a lot in improving access to vaccines, maintaining vaccines equity, and also reducing the number of zero dose and under-immunized children in the country. Though immunization coverage rates is uneven across the regions and population groups, especially in hard-to-reach areas, riverine, such as riverine communities, very, very remote communities which are not accessible by road or by air. This has really made immunization gaps across the country uneven, especially also in urban slums like cities of Douala, where we have numerous amount of urban slums harboring huge amount of zero-dose children. And this brings us to an opportunity, which means that if we can structure and quickly assess the mindset barriers, we can produce strategies and innovations that can reduce immunization coverage gaps, and that can reduce the high number of drop rates and also reach zero-dose and under-immunized children. Next slide. So CBT comes then into Cameroon at a very, very important moment where the EPI program is looking for approaches that can really, really reach zero-dose and immunized children. Approaches that are community-based, community-led champion, community-driven, and community data-backed to really, really identify which zero-dose and under-immunized children. So CBT approach came at a very important time also when Cameroon is looking at implementing its FPP project. Like at the moment, I'm currently in the capital city of Yaoundé, where we are also discussing how CBT can be improved and can be engaged in the FPP implementation. So for us, these findings were very, very critical at this moment, and they are a very rich resource to inform how our FPP implementation we go. So what the key thing we realized during our findings, Cameroon, is all stakeholders see CBT as very crucial in identifying missed children, seeing CBT very crucial in also identifying who drop out children and reaching communities that are not formally reached with our formal health system. Also, all stakeholders see community-based tracking as very important in giving more granular information that is very needed in micro-planning, and also an important resource and to capture community data that can lead us to answer the question, where are zero-dose children, who they are, and why they are zero-dose in the first place. So we realize that CBT data is very actionable in terms of micro-planning. CBT provides real-time feedback on service quality and caregivers' experience. It can give health facilities information about their immunization programs, whether they align to community's perspective and whether they are meeting community needs. CBT data also allows adjustments of service deliveries, find out whether the strategies that are currently being deployed are meeting the needs of the communities or not. So CBT data is very important to inform the program on whether the strategies are working or they are not working, and what needs to be improved and what needs to be re-strategized. Data from community also often shared with health facilities can strengthen feedback loops between facilities and communities, where facilities can better be informed on when to carry out campaigns, how campaigns should look like, and who are the key stakeholders to engage during immunization campaigns. Stakeholders strongly endorse CBT for data enhancing because we believe if CBT is institutionalized, it will give us that it will be a very particular tool for us to learn and adapt our immunization strategies. It will also give us a data-rich information for our advocacy. It is very, very important. This data now can be used for policy reforms, resource allocation, and strategic alignment. Next slide. So we realize in Cameroon that there are several data gaps and challenges, and we see that CBT position itself to fill in some of these data gaps and challenges. Leadership and management, we realize that there is not at the moment a data that shows the performance of governance and leadership structures in terms of immunization. And also this ineffective collaboration between CSOs and communities and government is hard to examine and address. There is no visibility on finance data. Communities do not know what was programmed for their immunization activities. They do not know what was programmed, what was budgeted for, and thus they have no visibility if actually what was budgeted for was what was actually used. So vaccination campaign data is not accessible to communities, and thus effectiveness cannot be measured. Vaccine logistics is largely partnered by and driven by UNICEF, and thus the data on vaccine logistics is within cold chains and not visible by community members. And CBT, we say CBT plays a very important role to bring out this data for community monitoring. Human resource capacity. We all know human resources are very crucial in immunization. What is the data available for us to be able, do we have the required human resource to meet our immunization goal? Those data, that data is not available, and CBT position itself very key in making sure we have data on human resource. Next slide, please. So what were our recommendations and conclusions? We saw that if a CBT can be institutionalized in the EPR program, involving all stakeholders, it will go a long way to help our immunization program performance and bring forth community perspective that will really drive immunization in Cameroon. We need to integrate CBT data into the JSS2. We need to know what are the contributions of civil societies and communities to our immunization program, because if it's not all about action, it's not all about engaging, but it's all about recognizing what the contribution is, quantifying and measuring the contribution of civil societies and communities to the program. National EPR Director should set the tone for civil society and community engagement. We say it all stands with the country. As Gavi 6.0 is more country focus, we say national EPR program should be the main key actor to set the tone for CBT in country. And we also say EPR managers, sales partners, and communities see CBT as very important. However, they should be effectively collaborated to work as equal partners with a shared vision, a shared understanding, and mutual respect and recognition for one another. The training for CSOs is very important, ensuring adequate funding and support, and leveraging CBT data for advocacy is very important. And also giving feedback on how CBT data has informed policies or strategy restructuring is very important during this period. Next slide. So we conclude by saying we see CBT as very, very important, especially in Cameroon, where we are looking forward our FPP implementation. We have begun our launch of FPP in the far north and in the north, and we'll be moving in other regions. We are right now at the capital city discussing on how we can leverage these findings, not only to say, okay, this is what was found, but also putting these findings into action. CBT is very important when it is institutionalized, when it is sustained, and when the capacity of all important stakeholders are built to effectively collaborate, and thus we'll see gains of CBT in Cameroon. Thank you.
Thank you so much, Dr. Mbianke. That was really good. You touched on the importance of CBT for understanding the why, the who, the why, the where of zero-dose children, improving micro-planning, and gathering user perspective to improve quality of immunization service. So I'm going to now move on to the next country, which is Madagascar. It's my pleasure to introduce my colleague, Nimi George Will. She's my colleague at IVAC. She will be presenting on behalf of our Madagascar colleagues who could not be here today. So Nimi, over to you. You have 10 minutes, please. Thank you.
Thank you, Dr. Chizoba, and thank you very much to everyone for being here. And I'm pleased to walk through the Madagascar findings on behalf of Hosea and the Madagascar colleagues. So to start with a bit of context on Madagascar, Madagascar has a population of around 30 million people, as projected by the UN for 2024. And over 60% of that population lives in rural areas, many of which are hard to reach due to geographic barriers. And the country is divided into 23 regions under a decentralized government system, which impacts how the health services are coordinated. And when it comes to immunization, the program is overseen by the EPI and supported by Gavi, the WHO, and UNICEF. And the services are primarily delivered via public health centers and outreach, but there's still a heavy reliance on external funding. So one of the main challenges is uneven service delivery, especially in remote and nomadic areas where children are more likely to be missed. Next slide, please. Now let's take a closer look at immunization in Madagascar. So in 2023, Madagascar had an estimated 251,000 zero-dose children, meaning infants who didn't receive even the first dose of DTP. Now, between 2019 and 2023, the country achieved a 16% reduction in zero-dose children. So while there has been progress, there's still clearly some persistent gaps. And if you look at the coverage data from DTP3 up until Penta3, it varies from 74% to 86%. So while the initial doses are being taken up fairly well, there's some drop-off across the series, and which reflects challenges with continuity and follow-up. And if you look at the graph to the right, the green line reflects the WHO and UNICEF estimates for DTP3, while the blue dots represent the official country reports. And so you can see there's a very noticeable variation between them, which just reinforces again how important it is to improve data harmonization and accuracy. Next slide, please. Okay, so we're diving right into the CBT status in Madagascar. And when it comes to immunization data systems, one of the big challenges is how fragmented and informal the data still is, especially at the community level. And facility-based reporting happens through the DHIS2, but community data is often paper-based and still unstructured. So you can imagine that this makes it even harder to track children who've missed their vaccines, especially zero-dose children. And right now, there is no standard tool for tracking defaulters or zero-dose children. And on top of that, a lot of the data collected by the CSOs doesn't feed into the national systems. So that means some of the most vulnerable children, particularly those in the remote areas, are still likely being undercounted or missed entirely. And another issue is there's not always context. So data on why a child wasn't vaccinated is rarely captured. For example, was it an access issue? Was it refusal? Was it a stockout issue? And these qualitative reasons aren't showing up in the data. And then to add to that, even things like caregiver held immunization cards aren't consistently available. So that makes follow-up even harder. So while there is clearly a system in Madagascar, there are major gaps, and that's where CBT has come in and started to make a difference. And now I want to move into the key findings from Madagascar. Next slide, please. So through the work that the CBT has been in Madagascar, the CSOs are leading in Madagascar, we've seen some important patterns emerge. So first of all, from the tools themselves, especially the paper-based tools, they're slowing things down. They create delays, sometimes errors, and they're difficult to manage at a wide scale. And while volunteers are the backbone of this important tool, they're doing great work, but they're facing burnout, especially when there's little or no incentive for the time that they're offering. And there's also been some resistance that was highlighted. A few Ministry of Health officials are still hesitant, or they're skeptical about, CSO involvement or capacity. And on top of that, the fact that there's no formal CBT policy in place yet creates uncertainty about how this work fits into the bigger picture. And of course, Madagascar's landscape, again, makes logistics challenging, whether it's cold chain maintenance, stockouts, and just the physical difficulty of reaching certain communities, all add to the complexity and the challenges with CBT in Madagascar. But even with all of that, there are still enablers, and one of them was strong partnerships between CSOs and district health offices, officials, and which have helped drive forward progress. And there's also digital tools like the Kobo Collect in Madagascar, which are being piloted to reduce the paper-based errors that I highlighted earlier as one of the challenges. And there's also good engagement from community volunteers and leaders who help bridge gaps in trust. And one standout example was the National Big Catch-Up campaign, which brought together multiple stakeholders and showed what collaboration at a larger scale can look like. So despite the challenges, there are solid foundations in Madagascar to build on. Next slide, please. So to wrap up, based on what we've seen and what the findings have highlighted, there are a few priority areas moving forward. First, Madagascar needs to formalize CBT through national guidelines, standard tracking tools, and just full integration of community data into the DHIS2 and microplanning. And I believe this was echoed by the other colleagues from Bangladesh and Madagascar, Cameroon. And right now, CBT is filling an important gap, but it's still operating on the margins. So it needs to be brought into the center of the immunization strategy. And second, there needs to be more investment in resources. Like I said earlier, volunteers are the backbone of the work, and they need structured training to build their capacity. They need meaningful incentives and better tools so they're not burnt out. And these tools can include, digital platforms, coaching infrastructure, as well as funding for outreach that's being led by the CSOs. And third, there's a need to go beyond just tracking coverage and to start understanding why children are being missed. So the qualitative reasons I highlighted before will make the data more actionable. And there's a need to harmonize CSO data with national systems so that the districts have access to it as well in real time. And lastly, partnerships matter. Partnerships are always important. Strengthening the Ministry of Health and CSO relationships through formal agreements is essential. And there's a need to engage local authorities, create peer learning platforms, and support large-scale outreach efforts. And to wrap up, the potential is clearly there. CBT has already shown that it can help reach the most vulnerable children. And so the next step is just making it sustainable, integrated, and fully resourced. Thank you.
Thank you so much for that, Nimi. Excellent presentation on behalf of our colleagues from Madagascar. You touched on a number of things. One, the idea that community-based tracking happens, but it's still paper-based and still slow. The idea that the community volunteers are the backbone of collecting this information that is not mainstreamed, yet they are, they are lacking in incentives and they are suffering burnout. You also mentioned that the lack of policy frameworks and guidelines is an impediment which we must overcome if we want to sustain and mainstream community-based tracking. And then finally, partnership with government is key to bring the community-based voice and tracking to the center of immunization programming. Excellent work. So I'll move over now to Nigeria to introduce my colleague. Let's see, who's from Nigeria? Goodness?
I believe Goodness Hadley, our CPM Goodness Hadley is joined. Thank you.
Goodness Hadley. Okay, so Goodness, the floor is yours. Thank you very much.
All right, thank you very much, Dr. Chizoba. Please confirm you can hear me.
Yes, we can hear you, and you have 10 minutes, please.
And can you see me? Because I can't see my video.
We can see you.
All right. Okay, great conversations. And it's very timely. We just finished here in Nigeria, Lagos, Nigeria. We just finished a discussion around health financing, especially for routine immunization and the HPV vaccination. So very important to speak to how, CSOs can increase, accountability and just garner support towards, mobilizing resource for health. and also mobilizing demand as well, because those are some of the things that we, talked about. So this is very, very timely conversation. So just to give a bit of context around Nigeria, Nigeria is a very populous nation. So what that means is that we have a huge target, to meet. And if we don't meet, our vaccination target, there's a lot of disparity and a lot of unprotected children. So for the combat, just like my other colleagues, the combat project was a mixed method project where we employed quantitative and qualitative approaches to inquire about, the current state of community-based tracking in Nigeria. What are the use cases? What are the successes with that? And how we can improve that to strengthen routine immunization. And it's very timely because we are seeing, dwindling donor funds in Nigeria. Gavi is set to transition from Nigeria in a few years to come, like all things going according to process. That's the plan. And we now need to discuss how do we sustain the gains that we have gotten so far from, the routinization. And in Nigeria, just to give a bit of background, because you hear me talk about LGA, you hear me talk about ward settlement. So in Nigeria, our administrative division is from the national to the state level to the LGA. So the LGA, which some other countries call district, and then the ward levels and the settlements, which are also the communities. Next slide, please. Next slide, yes. So also as a bit of background, Nigeria is hosting the most zero-dose children as of 2024. We are hosting the most zero-dose children. About 2 million children have not been reached with any vaccine. And we have also the highest cases of measles in Nigeria. And this speaks to a lot of factors, right? Supply side factors, but also demand side factors, because there's a lot of distrust and, just the lack of the appreciation of the benefits of vaccine that will result in this huge number of children not being reached with any vaccines at all. We can see here that we have just about 39% of fully vaccinated children vaccinated with the most basic antigens. And it means that we have nearly 60% of children who are still either partially protected or totally unprotected. And, it also strengthens the need for these conversations and how CSOs can contribute to improving immunization in Nigeria. In Nigeria, we, through IVAC, conducted a mapping of CSOs because we wanted to begin to engineer a systemic, inclusion of CSOs into the routinization landscape. And we conducted a mapping that we're able to identify at least 900 unique CSOs. And there's a lot of work that we have done in instituted those CSOs into immunization planning and have them really affect the program positively. Next slide, please. All right, so when we did the combat research, we also wanted to find out, we wanted to come from a journey where we find out what the immunization challenges are, what CSOs are contributing to that, and how we can continue that, with CSOs, and what are the necessary tools and enabling environment that CSOs need to effectively monitor immunization. So some of the areas that we noticed were lacking the necessary data to even monitor performance and then improve performance where the healthcare worker behavior. So one of the things we found was we are not really monitoring quality of care in Nigeria. So, clients go to the primary healthcare facilities, they access service, but nobody is tracking how was the service, how was your after vaccination experience, what is the feedback, good or bad. So we're not tracking that quality of care. We're not tracking health worker behavior. Immunization financing is also something that we're not tracking effectively, and we don't have enough data, right, to effectively track. And the question will go to even us as participants in this, who are Nigerians, because I know a good number of us are here. How much do we need in the next 5 years to effectively finance health or to buy vaccines for the next 5 years? I can tell you that a lot of us here don't have the answer to those questions. So when we even, you know, in the program that we just finished, when we had those interactions with the Commissioner for Health, he asked us squarely, what are the numbers? What is the cost-benefit analysis? I'm going to meet with the Deputy Governor. What information do I take to him? So we don't even have enough, you know, bite-sized fingertips data to be able to, you know, track our immunization finance, both in the release of funds and in the accountability, and then for advocacy to policymakers, and also demand generation data. Demand is something that is dynamic, that always changes, right? So we don't have enough data to understand why people are not taking the vaccines today versus what that reason is, you know, tomorrow. Next slide, please. All right, so we now wanted to understand what is the current state of CBT in Nigeria? What do EPI managers perceive, you know, CBT as? How do CSOs perceive CBT? And we heard from EPI managers that CBT is valuable. They recognize community-based tracking as valuable. They also recognize community-led strategies as important and critical to having a responsive immunization program. And then their community level impact. We're also asked, you know, inquired from the EPI managers, what are the areas where CBT can actually be used, or what are the areas have you seen CBT being used? And they spoke to zero-dose children, identifying zero-dose children. A lot of these zero-dose children are in consequential geographies, as we like to call them, vulnerable populations, nomadic settlements. So sometimes it's tricky to identify, but you have, you know, community-based organizations and individuals in the community that are able to pinpoint, here is an emerging settlement, you need to go there with vaccines. Tracking newborns was another thing, right? Tracking newborns, capturing, you know, community feedback, and just building that relationship between the community and the program is something that we always say, that community level aspect is the bridge between the implementation at the highest levels and you know, the acceptance at the grassroots. So we can see here some of the areas of contribution to immunization. So engaging communities, ensuring and pushing for the completion of our immunization schedule, providing grassroots level feedback, and then just supporting catch-up strategies for an outreach. Next slide, please. All right, so we also wanted to understand what the knowledge was, and I really have to rush through this. So many CSOs in practice, they know CBT, and they've been involved in, you know, community-based you know, practices and approaches. However, as an instituted technical term, CBT is not what is used to describe what they do. So they can say community engagements, they can say you know, other community-based activities, but CBT as a term was not the instituted technical term for that approach. And CSOs use a mix of paper-based tools and electronic tools to collect, you know, CBT data. And, you know, like what I said earlier, CBT is credited with providing, you know, needed information for planning. For instance, we've had situations where, you know, the community has given feedback to health facilities to say, you are vaccinating at the wrong time. We are not available for the vaccinations. Why don't you change the time that you vaccinate to either earlier or later in the evenings? And that has given us, you know, results, especially one of the very quick examples is the COVID-19, you know, vaccination. We saw how we were able to change vaccination times based on the feedback from the community and had more people vaccinated. Next slide, please. All right, so I'll just speak a bit about CBT use cases. We just wanted to bring out some of the things, some of the tangible examples of how CBT has been used. And one very recent example was the HPV vaccine introduction. During the HPV vaccine introduction, through IVAC in Nigeria, we were able to mobilize CSOs, about 60 plus CSOs across, you know, all the states in Nigeria, and we're able to also raise and activate over 3,000 vaccine champions who worked in tandem with the vaccination teams to increase demand for the HPV vaccination. And that's a clear, and we saw results from that alluded, both by our Gavi and our national partners as well. So that's one key example of CBT. Now, in a state like Jigawa State, the leaders in Jigawa implemented a no vaccination, no naming initiative, where the religious leaders and the traditional leaders themselves were the ones that were, if you don't vaccinate, you will not be named in that community. So these are the examples of what we've been able to achieve with CBT. And you can see the impact is, increased community ownership, improved service delivery, and just, being able to reach the people that need to be reached with immunization. Next slide, please. And I really have to rush this because my time is up. And just like many of the other countries, challenges around resources, government alignment and integration, and just that coordination between CSOs themselves as peers, and then CSOs and the government. And enablers were around institutional acceptance, improved capacity, where CSOs have the capacity, they are able to better monitor the program and contribute. And then funding and resource allocation, regular engagement. Many of the things we got were, when you engage us early in the planning, we're able to contribute, tangibly to the program. And that's one of the things that we got as the enablers. And on the opposite side, as a challenge for CBT. So the key recommendations, what are the key recommendations that we got from, next slide please, from our findings? One of the main things that the CSO said, especially on the quantitative, on the survey bit, was around funding and financial resources. Of course, if they need to really do this work the way they need to do, they need the resources. They also need capacity. So there are recommendations around building capacity. Also, there are recommendations around improving coordination, right? So embedding CSOs into those groups and forums where they will contribute to the planning, not just the implementation, but the planning, and add their community context to ensure that our planning is responsive and is targeted. And then harmonizing that data, finding a middle ground where we are institutionalizing CBT data and integrating that into mainstream government data. And I'm going to close with this because I think we're at the end. I'm going to close with this story. I was in an engagement where we're talking about community level partnerships for immunization, right? And one of the things that came out of there was that when they presented the data, the program people, they said there were gaps in the data, and they said, we don't know this. We couldn't find this, we couldn't detect this. But when we talked with the community people, they told us, they actually filled in those gaps for us. They told us how they were able to penetrate into the community and get the people that the program people were not able to get. And it reinforces the need for that community connection, right? So these were some of the recommendations that were made. Next slide, please. I think I'm at the end of, next slide.
That is your last slide. Yep.
All right. So thank you very much. These are some of the recommendations and some of the findings from Nigeria, and we're very happy to continue that conversation. Thank you, and over.
Thank you so much, Goodness Hadley.
Just wanted to thank everybody for the wonderful insights at the country level, and send obviously our thoughts and prayers to our colleagues in Madagascar for hopefully everyone during the current unrest. We are thinking about them. We wanted to kind of move to the panel discussion, and I was just going to briefly introduce the folks, the colleagues who've been wonderful, grateful for their joining us today. Mr. Abu Yusuf Chaudhry is the chairman of the Bangladesh CSO Coalition for Health and Immunization, BACI. And so BACI is one of the largest CSO networks in Bangladesh, and he also was a contributor and a participant for the combat study. So we are grateful for him to share his insights. Dr. Pamela Basong is a pharmacist and a global health professional who has been managing diverse health programs in Cameroon. So she currently coordinates the EPI in the southwest region of Cameroon. So we are delighted that she's here to share her insight as she's collaborated with international and local organizations to reach thousands of zero-dose children with life-saving vaccines. We have Ms. Bitan, who is the executive director of the GEM Hub initiative. The goal is to empower youth as precious stones through health education and economic resilience programs. And so she is an advocate for equity and youth empowerment, as well as policy reform, and really champions advocacy at the global and national level. And last but never least is our fearless leader needs no introduction, certainly deserves all the credit for sort of spearheading these efforts. Dr. Chizobo Winodi will be our facilitator. She's an associate scientist at IVAC, and she's our Nigeria country director. So she has also held leadership positions for USAID. She's a public health physician with expertise in immunization delivery, program delivery, implementation, science, behavioral science. So we look forward to hearing everyone's comments. I'll go ahead and stop sharing and go ahead and put myself on mute so we can hear from our colleagues. Thank you.
Excellent. Thank you so much, Victoria, for that introduction. I'll just go into the questions for the panelists. So what I'm going to do is I will direct specific questions to the different panelists. So I'm going to start by saying that in this panel discussion, we really want to emphasize or rather reiterate what we have learned about the value of CBT, the importance that's accorded CBT by communities, and issues around integration. So on value, this question goes to Ms. Pitan Yemi. We've heard in the presentations how CBT has been described as a strategic tool for immunization, whether it's to help identify zero-dose children, understand why they're zero-dose and where they are, or even if it is to track service delivery quality. From your own experience, I know you've done a lot of work in Nigeria. From your own experience, what has been the most valuable contribution of community-based tracking to immunization outcomes from your experience?
Thank you so much, Dr. Chizoba. Thank you for having me. Hi, everyone. So from my experience, community-based tracking has been so impactful in putting narratives to the numbers, just like has been shared earlier by different presenters, beyond the figures. Because when we hear, oh, one person has died, that's actually a human that has died. Or when you say, oh, just 53 people, 53 people are not just, they have stories behind them, right? So that's the same thing for what does the value that the community-based tracking actually gives. It gives the feedback, but the narratives behind the feedback. What is the reason for the barrier, right? If you're saying that, okay, we have 1 million zero-dose in this particular community, for example, why are they not being vaccinated? Community-based tracking gives the story to that. So that's number one. It gives the narrative, it gives context. And once that information is being used to appropriately, for example, if it's captured, so that's the gap in terms of if it is captured appropriately and then is informing decision, then that's ensuring that it's being maximized from the beginning to the end. So I would say it gives the context and it's so helpful in making decisions. That's number one impact the community-based tracking helps. Number two is it also gives feedback because it's the community, they are the ones feeling whatever it is. They are the ones facing the barriers. For example, I remember during the focus group discussion we had on the combat, one of the participants is a CSO, someone with disability, actually also mentioned the fact that when we're trying to probably design a program and you're looking for communities, because at the end of the day, communities is beyond the physical or geographic community, right? There are communities of people with disabilities, for example. She also highlighted the fact that they are not homogeneous, they're also heterogeneous. For example, heterogeneous with different needs. And so when you're talking to one person with disability, that person may not even be able to give you a reflection of what all the people with disabilities are facing. So, for example, what a blind person needs is different from what someone on the wheelchair will need, for example, or someone who cannot talk, for example. And for a deaf person, how is this person, if there's no facility in the primary health care to communicate to this person, how would this person be able to be set appropriately or give a feedback as to the quality of service being rendered? So if community-based tracking is used effectively, we are able to get the experience, the lived-in experience of communities, which is able to improve programs.
Thank you so much. I think what you said resonates with me in the sense that with community-based tracking, you're able to get the stories, the narratives behind the numbers. And we know that storytelling is one of the powerful tools that we have in our toolbox for advocacy. If we are not connected with the communities, we will not know the story of the twins, for example, in Dabangaza community, who I think one of them died because of typhoid and things like that. And those are the stories that actually move. Two of them died, yes. So if you're not in the community, if you're not entrenched and collecting those information, you will not have the storytelling to move. And then the other point you make is that community is not just about a physical location or one village somewhere. Community could be defined as groups of people who have like a particular interest, like communities of people with disabilities, communities of people who are homeless. So in defining our communities, we should be more expansive to make sure we leave no one behind. So that's excellent. Thank you very much for that. So I will now go to our colleague from Bangladesh. And then I want to ask specifically on the issue of challenges, right? So several presentations pointed to persistent data gaps, particularly around financing, demand generation, and governance. In your experience working in Bangladesh, I know the Bangladeshi presentation highlighted the progress that Bangladesh has made on immunization. However, in your experience, how can community-based tracking best help to close, be it gap in financing, gap in demand generation, or gap in governance? How can we leverage community-based tracking effectively to close these gaps without overburdening communities with data collection tasks? Because recall, in some presentations, they talked about burnout without incentives. So can you tell us from your experience how we can do that? Thank you.
Thank you very much. I am Abhishek Chaudhary. Thank you. First of all, as you know that our system in Bangladesh is more government-oriented. It's not that much of CSO-oriented. There are two parts. In urban areas, the CSOs help in immunizing the children to the government system. And that's in the urban area. But in the rural area, is the government health worker actually who give all the efforts for providing immunization services. Yes, in that case, the local, I should say, NGOs or CBOs, they help in mobilizing the mothers to come to the service center. But in the way we are, the subject that we are discussing about today is those children who are missed and who are under immunized. That's a different thing, in my opinion. And I don't think that this part, those children, NGO has taken any responsibility to identify them and take lead for the vaccination, except in a few cases. Okay. It's not generalized. But yeah, it's not generalized. But what I think that the subject of the study, the study has identified actually some constraint or other things. What I can give actually at this point my views that in increasing involving reducing the reduce children, the community involvement is a must, because those children, they live in the remote area, inaccessible area, and vulnerable communities. Usually, they are health workers and other groups, they don't have access to them. Yeah. In that case, even the NGOs so what are the solutions actually? So what I see that the basic thing is the zero-dose population. How we cover them. If we want to do that, I would suggest that the whole approach should be concentrated to the to the geographical areas, to the pockets where there are concentration of zero-dose children or unwell children. It's not too common, because in our case, its coverage is very high. But we are concerned in some pockets about the zero-dose children.
Okay. So Bangladesh is a specific context where you have generally pockets of zero-dose children.
I am going to ask the last question on her behalf, and I'm going to ask Dr. Pamela. I know that you you're working sort of leading a regional program, and our question has to do with integration. I think a lot of folks here have talked about partnerships, have talked about collaboration, have talked about bringing the necessary people around the table. And I just wanted to ask, the one recurring theme is that CBT is often driven by CSOs or partners and not fully embedded in national systems. What practical steps do you think, and I'm sort of asking you across the desk, what practical steps could CSOs or donors take to make CBT, at the community level, a permanent part or a more operational part of national immunization programs, rather than a separate or standalone program or project as one-off by sort of CSOs or donors? Your thoughts, Dr. Pamela, as sort of as part of the institution that is working so hard.
Okay, thank you so much, Victoria, and thank you for inviting me. Like you clearly, all the presenters have said, CBT is not new. We've been integrating CBT, and it has other names in my country. Now, talking of integration and let me say institutionalization and also sustainability, it's actually very important and key if we want to see how CBT contributes to improving immunization in my country and in other countries as well. So I think the first thing is to promote local ownership in the sense where the community considers CBT as their contribution to health. So it's not more of the meaning this is something that is led by the Ministry of Health, or we need to depend on external funding to be able to carry out these activities, but more in the sense that the community sees it as this is our active role and engagement in contributing to our health. So it is not anybody's health, it is our health, it's the health of our children. And how can they do this? They can do this by contributing in other forms, other resources in other forms. It could be material resources, it could be providing human resource, it could be communication. All of this, I think, would go a long way in promoting CBT. At the health facility level, I think this can be carried out in the fact that most health facilities produce some sort of income, and this income can be in a way set aside to promote CBT activities. if a community health worker needs to go out, maybe to carry out home visits or to carry out sensitization in the community, the health facility that generates income can chip in something to support these activities. And this way, we see that CBT is an integrated form of primary health care where the health facility as well owns this activity and is able to carry out the activity sustainably. Now, looking at it in the national sense, or at the national EPI program, we spoke about the fact that there are no guidelines for CBT. So there is need to be able to come up to elaborate guidelines for CBT. How is CBT going to take part in our country? How is it going to be contextualized? And talking about contextualization again, at the local level, at the community level, at the health area level, it's important to use these guidelines contextually to ensure that these CBT guidelines are culturally sensitive and they're able to meet the needs of the different communities. So I think that these are the different approaches which come to mind and which will be very useful for CBT. Thank you.
Thank you so much. No, we appreciate all of your thoughts and the feedback from our panelists. And I apologize that we wish we could had another half hour. We sort of, what we wanted to do is we just wanted to let you know what would be available. This webinar has been recorded. The report from the Combat Project that sort of details some of the global findings, sort of pulling across what was across all four contexts was the similarities, as well as the individual countries, their really detailed deep dive into what their current status is for CBT and what some of the challenges are that may be context specific. But we wanted to conclude, we cannot end without a hearty, deep appreciation for all of the folks listed on here, as well as all of you that have taken time to join us. We could not have carried out this work here at IVAC without our in-country partners, guided by our wonderful technical advisory group that sort of reviewed information, would give us key pointers and really helped become our North Star. And then last but never least, we appreciate our colleagues at Gavi, the Vaccine Alliance, as the work does move forward to the country level. Some of the recommendations, some of the suggestions about next steps, we hope will be part of Gavi's work in the future and as well as all of ours. So we really, again, take this opportunity to thank everyone for joining. I know days are busy, depending on where you are, days are long. And so we are grateful for your comments, your feedback, your input, and we hope to continue the conversation moving forward. So thank you on behalf of the Combat Project. And Chizoba, if you're able to unmute, and if not, we will meet again. Go ahead, over to you.
Thank you very much, everyone. That was an interesting sharing of ideas and findings. I want to say big appreciation to the speakers, to the panelists, of course, to Gavi, who funded this work, and to my colleagues who pulled this all together, Victoria and Mimi and Tori. Wonderful work. Thank you so much.